a pleasure to be here for my very first time. Had an opportunity to participate in part of yesterday and this morning, and really what a terrific conference. I am so pleased to be a part of it. And thank you, Rick, for that introduction. I thought what I would do today, because this conversation is supposed to be about what's going on in the market, is take a page out of Governor Newsom's playbook from just earlier this week, his State of the State address, and talk about just one thing. And that just one thing is healthcare affordability. I believe that the issue of healthcare affordability is the issue, will be largely the only issue that we talk about collectively and on our own over the next several years. And it is the issue that will really define what healthcare looks like moving ahead. As Rick mentioned, I've had a pleasure of serving here in the state of California and many years before that in Washington, D.C. So as I think about this, perhaps I should have been on the California panel yesterday, but I do think that especially in this issue of healthcare affordability, while it will be a national conversation and discussion, we are going to lead that discussion here, and it's going to happen first in the state of California, and that is being pressed by many, many factors, including the fact that we have millions and millions of people to care for in this state. So always love this cartoon as we take a look at the view from California, nothing like a New Yorker. We can sort of see the Statue of Liberty down there, and I think that's Mexico off to the right. But I will talk about the view of this topic from California, but of course, it's about California and beyond. As they say, as California goes, so goes the nation. And just want to remind us, we have some incredibly influential and smart and powerful people, not only here in California, but in the nation's capital, who come from a Californian perspective. And I think that's important as this conversation continues. So, what I'd like to do is just a brief reminder and do a little compare and contrast of policymaking and how we think about these issues in Washington, D.C., and then back to California. This is a map you're probably all familiar with, and it is the current makeup of parties in the U.S. Congress, both in terms of the House of Representatives and the Senate of the United States. And the takeaway here, of course, is that at this point in time, it's not exactly, but it's a pretty balanced match in terms of Democratic and Republican perspectives in Washington, D.C. And the important part about that is that that means that these conversations about major issues often take more time, have more of a balanced dialogue back and forth, and open debate about these issues and what the potential solutions might be. Let me just remind you and contrast that with the political makeup in the state of California. As you can see, and as I know you all know, a more Democratic leaning, of course, both Assembly and Senate. We can count Republicans on our fingers and toes now in the Assembly in California. But the point is it makes, and regardless of your personal politics, the point is it makes for a very different process as we consider these big issues. And in this case, generally more party cohesion about these conversations. That makes for often less dialogue back and forth and a much more rapid pace of change. And that's part of the reason that I think we're going to have some very significant and important conversations about healthcare affordability, first in the state of California, before that turns to a broader national conversation. So with that, some polling data, you've seen plenty, and you may have seen this slide yesterday. This is from January, but I thought this one was very important. As we take a look at healthcare, of course, the public is concerned about a whole host of things. But in particular, and we know that elected officials in Washington, D.C. were watching this very closely, the top priority in the minds of the voting public is prescription drug prices, followed on closely by lowering what people have to pay for health care, protecting people from surprise bills. But the reason I think this poll was actually done is because, of course, in the Democratic presidential debates that we've all been watching early on, the conversation was all about Medicare for all. And it really dominated the airwaves, dominated the discussion. But I think what this polling data tells us is that is not what is first and foremost on the minds of most Americans. It is back at this end of the polling data, and that is all about prescription drug prices. I know there was a panel here yesterday, and that is why Wendell Primus is so busy in his work on looking at and advancing legislation related to prescription drug pricing in Washington, D.C. So, as we take a look at the issue of affordability, I'd like to make a comment before I move on with a couple of additional slides. And that comment is about, and really this presentation is about, how difficult it is going to be for us to put our arms around this issue and tackle it in a thoughtful way. And I want to be very clear, that does not mean we should not do it. We need to do this. I will tell you, California's hospitals will be at the forefront in helping to put solutions on the table, but it's going to be very, very difficult. And that is because inherent in this conversation about making care more affordable, I believe we will find ourselves faced with more and more ethical questions and conversations about what it is we want out of the healthcare system. The challenge with affordability, I believe, is that we can, in this day and age in healthcare, literally perform miracles. And for the clinicians in the room, I have such deep respect for what you are able to do, for the technology, even the data capabilities we were just talking about that enhance our ability not only to advance the quality of life for individuals, but to actually save more lives than we have been able to save before. This is an incredible set of capabilities, and it's really expensive. And our challenge is the cost of being able to do these things has rapidly outpaced not only the ability of a typical Californian, but the ability of a typical American to afford those interventions and a better life, and life itself. That's the core of the difficult conversation I believe we need to have, and we need to have it very openly and very honestly. Let me do that with an example, and this happens to be an example of pharmaceuticals, but that's just because there was a fascinating article that I was looking at recently. The title of that article, Most Expensive Drugs, Period. And for those non-clinicians in the room, the one at the top of the list is a drug that addresses a condition known as spinal muscular atrophy. And Rick and other clinicians will correct me as I go through this, but very simply, this is a devastating condition in young children, infants, affecting their spine. And not only the majority, but nearly all of these children die from this condition. There is a new drug that holds the hope of helping some of those children live. And the price of this drug ranges from $2 to $3 million per child. And the challenge that I think we face is, if that was your child, I will tell you, if it was my child, I would sell everything I owned. I would mortgage my home. I would do anything I possibly could to be able to provide that drug for my child. Now, we are having an open conversation about prescription drug pricing and whether that is a fair price for that drug, but we are going to be engaged in an ethical dilemma about what we can do, how much we can do, how much we can pay, and those are not easy or simple solutions. If we look at technology more broadly, and this is just one example, imaging equipment, we use it every day, right, in the nation's hospitals. We are using it in physicians' offices and other centers. And again, it's expensive, multi-million dollars for activities that we now take for granted in terms of imaging. Not to mention the cemented rooms, right, that these things have to be buried in order to make certain that they are safe for the people who are working around them. It is an expensive proposition. And labor. Hospitals, as I have often said, and hospital care especially, is all about people taking care of people. What we do in our hospitals is people putting hands on the patients that we have the privilege to care for. And it's expensive. In California, it's especially expensive. Average nurse wage in the state of California, $51, which is 42% above the national average. Why is that? Well, first and foremost, everything in California is expensive. I am now just more than 2 years in the state of California, and I can't believe it. I know people call it the sunshine tax and all the rest. California is just an expensive place to be. The cost of living is extraordinarily high. But in California, we also have a long and rich history of labor and labor organization, and that makes the price of labor different in the state of California than it is in most of the rest of the United States. So providing care, people, helping people, is an expensive proposition. And adding that all up, I'll just show you from the hospital perspective, because that happens to be the one I come from, the distribution of our costs, where 56% of a typical hospital's costs are comprised of labor. Another 15% supplies, so right there, 71% of the costs associated with hospital care are labor and the things that we need in order to provide that care to an individual patient. And the reason that I raise this, because it's the more difficult conversation we have to have, it is very easy to say we need to make care more affordable, and perhaps we just should pay less, whether that's for hospital care or physician care or nursing home care or any of the other components, drugs included, and we have to think about what the implications are of doing that. I have often used the analogy, it's like going to a restaurant and you get a check for $20 and you leave a 10 on the table. That might be more affordable for you, but we've done nothing to actually reduce the underlying cost of care, and that's the challenge we collectively have to put our arms around. How do we actually rethink how we deliver care, get at the underlying cost of care, reduce unnecessary utilization? But the easy button and simply paying less is not a workable solution. We in this state are talking about and wrestling with homelessness, as the governor talked about earlier this week. And part of that is the affordability of housing in the state of California. But we're not talking about paying builders less for their homes. Healthcare is equally as complex as the housing issue. We need to come together, think about those solutions, and put them together in a continuum that lets us approach this thoughtfully and avoid some of the unintended consequences that I don't think anybody really wants us to face. I want to resonate a little bit with Chrissy Eibner's presentation from yesterday, for those of you who were here, and it's with this statistic about healthcare spending in California. And that is and it both is true of hospital care spending and healthcare spending in the state of California. It is lower than it is in the rest of the nation. Hospital care spending is actually in the bottom quartile of spending in the nation. And if you remember from Chrissy's presentation yesterday, one of the things she noted was because California has this history of significant managed care penetration, we have already used some of the tools and techniques that haven't yet been adopted in other places in the United States, which means that addressing affordability, if we're just thinking about it within the borders of our state, is going to be even more difficult, as she pointed out, because some of that low-hanging fruit has already been grabbed onto. So we're going to have to think even more carefully in California than they have to think in other states, and be more careful about the choices in front of us. So as I think about healthcare affordability, I'd like to share with you a framework in which I think about it. I much prefer a conversation about affordability than I do of cost containment. Cost containment seems to be a conversation about simply paying less for what we are providing today. Affordability is a more important conversation. And it's because the concept of affordability has both a numerator and a denominator. The numerator is the cost of healthcare services. Absolutely, we have to focus on that. And the denominator is the economic circumstance of a typical American, or here, a typical Californian. We've got to think about affordability in the context of everything else that is going on in the world of a Californian. And that means education and job opportunities and the economy and all of the rest. Having that numerator and denominator makes us think more completely about how we go about addressing this issue and for whom this issue needs to be addressed most quickly. On with the framework, I think about it in 3 tiers. Input prices into healthcare. We've talked already about drugs, labor, technology, and many more things that go into the provision of healthcare. If we don't address the input prices, we will not be able to address the overall cost of care. And I'll come back and talk about this, but for those who simply want to pay less for the final product, I remind us of the Nixon days, and they were Nixon wage and price freezes, not that I'm calling for wage freezes by any means, but you've got to think about the input prices as well as the prices in terms of the outcomes. Second, there is an important and significant role for providers of health care. We need to look at new payment models. I'll talk about one in a moment, and Chrissy referred to it yesterday in her presentation. But we also need to continue to work on creating a seamless care delivery system. Many of us have been saying this for decades. We are still not there. The previous panel and what we're able to do with data and technology is going to allow us to accelerate that like never before, but we still have handoffs that aren't seamless, duplication of service and care, and unnecessary use of services, especially when it comes to the chronically ill. Those are some of the new places, not so much new, those are some of the continued places we have to focus and continue to do better. And finally, payers and insurers. One of the most important questions we have to ask ourselves when we talk about affordability is, what do you mean by affordability? My belief at the end of the day, it's got to be more affordable for consumers, for the people of California and for the people in the United States. And that means not only the provision of care, but what they're paying out of pocket for insurance, and quite honestly, what they're paying out of pocket at CVS and Walgreens, I think there are no Walgreens here, and other places where we are shelling out considerably for nutritional supplements and all of the rest. We need to look at all of that to understand affordability. But my bias, we need to look at the payer piece of this and understand when is insurance not. I am very concerned about affordability for a typical consumer when we have shifted to high deductible plans where the coinsurance is, or excuse me, the deductible is $5,000 or $10,000, which is simply not typical for an American. So affordability can lead to various solutions. These are some that are being talked about. My concern is that many of these are a piece of the puzzle, not the entire puzzle, or overly simplistic. Lots has been said already about prescription drug pricing. I think it's very important that we focus on prescription drug pricing. Surprise billing was talked about yesterday. Let me provide my thoughts and you won't be surprised. Absolutely, patients have to be taken out of the middle in this issue of surprise billing. They should not be caught up in negotiations between providers of care and payers for care. That is not where the patient needs to be. We should not be charging patients more than the in-network rate for the care that they receive. But what goes on behind the scenes and the negotiations between providers and plans, whether we like it or not, is part of what it means to provide health care in a market-based system. And we have to be very, very careful. There have been many articles, and lots of them talking about who's really got the leverage in these negotiations. And there are people on both sides of this issues, well, the providers have more leverage, or the payers have more leverage. And the answer is, it depends. It depends on the payer, it depends on the provider, it depends on the market. It depends on the financial makeup of any particular provider's patient mix and many more factors. But the caution here, if we're trying to couple, as some would suggest, getting the patient out of the middle with setting a benchmark rate, we really risk mucking with the market and mucking with the incredible variability in that market to the detriment of access to health care. We need to be very, very careful. Do the first. My own belief, stay away from benchmark pricing because it could be very problematic and create challenges with access to care. Hospital rate setting. How can I be up here representing the California Hospital Association and hospitals and not talk about that? I spent 9 years in Maryland, which is the only all-payer hospital rate setting state in the United States. It was and is a successful model in the state of Maryland where we had an ability to reduce the rate of growth in hospital spend. That is a 40-year history, and the secret in Maryland is it is an all-payer rate-setting system. What that means is the rates are set for all payers, Medicare, Medicaid, and commercially insured. So in the rest of the United States, where Medicare pays 20% less than cost, Medicaid less than that, and commercially insured individuals have to pay more to allow us to make ends meet, the Maryland system has equalized all of that. They have filled those government underfunding buckets and been able to pull down the rates then paid by commercially insured patients. But what's being talked about in Washington, D.C., and what was talked about 2 years ago in California was rate setting, but it wasn't about filling the government underfunding, it was only about pulling down those commercial rates. And that would have been a hit to California's hospitals of $18 billion, which again, creates challenges with access to care. So these are more complicated. We've got to think about how they work together. Finally, Medicare for all. It is a very different, very bold way of thinking about healthcare and healthcare reform. The challenges. Medicare today, from a hospital perspective, reimbursing at 80 cents on the dollar. If that's what Medicare for all means, and all reimbursements go to 80 cents on the dollar, we will have significant challenges in the state of California and elsewhere. The governor, as you know, has a new commission that will be looking at a single-payer healthcare system in the state of California. That work will be done in the next year and a half. We look forward to working with that commission and understanding what the options may be. The challenge in particular for a state doing this on their own is that we have to give up that federal funding, the price tag, as you know, in the state of California for a Medicare for all-like option, $400 billion. Our entire state budget is $222 billion. So these are the kinds and orders of magnitude of options that are being discussed, but why they're so difficult to really implement. And let me begin to close out. The governor, in his budget earlier this year, announced the creation of a new Office of Healthcare Affordability. We are excited about this opportunity and looking forward as our money to working with the governor in defining this office and what it means. This conversation is the conversation we need to be having. In creating an Office of Healthcare Affordability, it will give us an opportunity, I believe, to have that conversation in a structured, organized, and thoughtful way. This office can really be the place where we look to for the data that we need to understand what are the key drivers at any point in time of healthcare affordability in the state of California. And it will allow us to bring multiple stakeholders together to have that conversation in a rational and thoughtful way. We look forward to working on the details. What is being thought about at the moment? Think a little bit like Massachusetts. Many of you may be familiar with Massachusetts. Chrissy was talking about it yesterday, where there is a desire to set a goal. What do we think a rate of affordability, a rate of increase in healthcare looks like that we could both make certain that we are helping consumers in the state of California and continue to protect access to care? What is that number? That's an important conversation and a thoughtful one that we need to have. How do we monitor that progress over time? What happens if a provider or a payer has rates of growth that exceed that? What do the consequences look like? And what does it mean to think about consequences that might be sector-wide if, in fact, some providers in that sector have done absolutely what they need to do and others haven't, or some payers have done exactly what they need to do and others haven't? How do we structure a system of investigation, a system of review, a system of performance improvement, and then think about what may happen after that so that we can be thoughtful in terms of creating affordability in the state of California. Let me quickly talk about three options. I just mentioned Massachusetts. The experience in Massachusetts in the last 4 or 5 years, they have met their goal on average. Their goal that was set was to limit the rate of increase in the total cost of care, a really important concept, to about 3.1%. They made the target the first year, exceeded the target in the next 2 years, made the target in the 4th year, but it is a thoughtful annual process for consideration. I think the model of what not to do is what's going on in New York right now, if you're following what's happening in New York. But this was a set of challenges that occurred because of how hard this is to do. So New York wanted to put a lid on their Medicaid spending in the state of New York, and they calculated a target, and now they've missed that target to the tune of $4 billion. So that is what Governor Cuomo is dealing with right now. He's got a $6 billion deficit, but $4 billion of that is Medicaid. Why? When they made the calculations of the cap they wanted to impose in New York, they made 4 estimating errors. The first was how many people were going to actually enroll in their Medicaid expansion. As a result, they underestimated the state expenditures. Second, and it was just a follow-on, they therefore overestimated the federal expenditures, and it created a gap. Third, they did not estimate, because they didn't anticipate, the impact of an increase in the minimum wage in the state of New York to $15 an hour. That increased the cost of health care. And finally, an underestimate of the aging of the population, which has resulted in more post-acute care use among the Medicaid population. 4 things, well-meaning, but it's an illustration of the challenges in setting a goal or a target and what it means. For me, well, let me do Maryland and then I'll give you a conclusion. Maryland, I spent 9 years there. We had success in setting some goals and targets, but the success was not just in the process of setting goals and targets. It was a 40-year history of rate setting in hospitals. What happened in Maryland is we were able to regulate hospital spending, but not other spending. So as hospitals, and especially when we moved to global budgets, began to focus on community health improvement and population health management, we saw visits to the hospital decline. But where did people go, right? More physician office visits, some more post-acute care visits, but the only lever we had was to turn down payments to hospitals. There were no levers to address the others in the system, even though we were measuring the total cost of care. So again, lessons, tools, caution, it's just not simple. My conclusion from this, the effort that we are about to undertake should not be about hitting a number. That's not the goal. If we wanted to hit a number, we could do that. If we wanted to spend less, we could do that very easily, right? We simply don't provide care for people. That's not what we're trying to do. We're trying to balance outcomes with cost, and we're trying to bend that cost curve in a way that is achievable. It's also very easy to set a target that is unachievable. One of the things we did in Maryland was to benchmark to the utilization rates in the states of Oregon and Washington to understand how much more unnecessary utilization could we pull out in Maryland. That is a very different calculus in the state of California, where we already have very low utilization rates and high penetration of managed care. So with that last slide, I think about affordability in a broader context and in a broader framework. First of all, it's about coverage expansion. We will continue to join with this governor, consumer advocates, and others. First and foremost, we'll make care more affordable if we get people coverage. They need to be able to get to their primary care and multiple sources of primary care in order to stay well in the first place, treat conditions when they are less severe before a hospital emergency room is their only option. These are just some of the things that we have been supportive of. An individual mandate in California covering undocumented individuals last year up to age 26, this year for undocumented seniors, and enhanced subsidies for those in California who were left with a cliff because of our high cost of living. Second, access. It's all about primary care. We do, as California hospitals, support the bill that will allow expanded activities on the part of nurse practitioners without supervision. Behavioral health, behavioral health, behavioral health. It is the #1 issue for California's hospitals. Again, as was said yesterday, and Rick, you did such a wonderful job. Our behavioral health challenges right now are being addressed in jails and emergency departments. We can and will do better. And by the way, when we do better in California, I hope for a while we're going to spend more on behavioral health before we are able to work that into savings overall. And health access and opportunities in our rural communities. Value. You see the things here: drug prices, out-of-network cost sharing, high-deductible health plans. One of the new payment models that Chrissy referred to yesterday are global budgets. The state of Maryland did move to global budgets. We are seeking to pilot the same here in the state of California, starting with our rural hospitals who today are trying to compete in a marketplace when they are very isolated, cannot attract physicians, but it's about maintaining access in those small and rural communities. So bottom line, this is the issue. The time is now. We all have to work together. Beware the simplistic solution. Beware the statement of the number to hit. We need to do this, but we need to do this thoughtfully so that we can both address the affordability of healthcare while continuing to provide the level and kind of care that people need when they need it and where they need it. With that, I thank you so much for the opportunity to join me today.